Hello everyone, and a very warm welcome to all of you to yet another episode of Medicine Unplugged. Now, Medicine Unplugged is a special integrated session that DAMS does on Facebook and YouTube, where we integrate different fields and see the patient as a whole. So we would look at the clinical aspects of the patient, we would follow it up with labs or radiological investigations, connect it to what could be the pathological findings and how would we manage the patient as a whole, right? So we are going to integrate different streams in the management of the patient. And today we have a very interesting case. So let's look at the case. So this was a 22-year-old woman who wanted to become pregnant, but she had no menses for past 1 year after she was taking OCPs and she stopped taking the pills. And since 1 year, she was complaining of amenorrhea. And recently, the patient developed galactorrhea, right? And on taking other histories, she was not on any medication. There were no headaches or visual symptoms. There were no features of dyspareunia or decreased libido. The physical examination was actually normal except for the bilateral breast discharge. Right, and we followed up this patient with the labs, so her HCG testing was negative. The TSH level turned out to be normal, and the most important thing, which you can see here, is that her serum prolactin level turned out to be 125, which is significantly raised. And because the serum prolactin levels were significantly raised, this patient was now advised an MRI brain, right?
Now, thank you, Dr. Deepthi, for the referral to the MRI. Now, although you have sent the patient to us for a MRI brain, but when we are suspecting a pituitary microadenoma, we want to go for a contrast-enhanced MRI. Another point that I want to add here is that even a routine contrast-enhanced MRI is not enough to look for pituitary microadenomas. We need to do something which is called as dynamic contrast-enhanced MRI. What do we mean by dynamic contrast-enhanced MRI? Let me show you a representative image. So when you look at this image, you can see we have taken a coronal section with a small field of view focusing on the pituitary gland, and we have taken serially timed images. You can see there is a scan done at 15 seconds, 30 seconds. The place is same, but we are doing, after giving IV contrast, we are, doing a serial MR to follow up the contrast enhancement pattern. The reason that we are trying to look for it is that the microadenomas usually enhanced slower than the normal pituitary gland. So that delay can be appreciated only on a dynamic scan. If we do a delay, even the gland and the tumor both would have enhanced, we might miss it. So we need to do a dynamic contrast scan. Let me show you now the images. Look at the first image. That is a non-contrast scan. We have done it to establish the baseline. Now, when we inject the IV contrast, it is first taken up by the pituitary stalk, then it goes to the pituitary tuft. Pituitary tuft is the area where the infundibular stalk and the gland are meeting. Then centrifugally the dye spreads to the entire gland of the pituitary. Now please see, can you see this? This is the gland which is enhancing, and we can start to appreciate an area which is relatively hypo-intense. It is not enhancing. You can see it even better in the further images. And this is a pituitary microadenoma. You can see pituitary microadenoma was identified because it is enhancing later than the normal gland. But look at now a delayed image. You can't appreciate the tumor any longer because it has become iso-intense to the gland, because the pituitary will be losing dye and the tumor is picking up dye at the delay stage. It's become iso-intense. Sometimes it may happen that you might see in a delayed scan pituitary microadenoma as a hyper-intense area, because that is now accumulating dye, but the gland is showing washout. It may happen, or it might be even seen as a hypo-intense in some patients. But you need to do a dynamic contrast enhanced MRI if you are looking for a pituitary microadenoma. Another point I want to add here is that by definition, if a tumor less than 10 mm in size, we call it microadenoma. More than 10 mm, we call it macroadenoma. Let me, now with these findings, now we know there is a sub-centimetric, millimetric size microadenoma here, which is enhancing later than the normal gland. Let us send the patient back to the clinician for further comments.
Right, and now we have the radiological report available with us. Our patient is a case of pituitary microadenoma or a prolactinoma. Now, a few things I want to highlight by going back to the history that we must understand. Most common presentation of pituitary microadenomas in premenopausal women are amenorrhea and infertility, and this is how this woman presented to us. And because any woman who presents to us with secondary amenorrhea, the first test that we should always do is rule out pregnancy, and that's what we did. Her HCG was negative. The two other tests which are absolutely important in a woman presenting to us with secondary amenorrhea are TSH and prolactin. And once the prolactin turned out to be high, that's when I suspected probably a pathology with the pituitary, most likely to be a pituitary microadenoma, because that is what is most common. These women may also have galactorrhea. It can be seen in up to 80% of the patients, and this is what our patient also had, right? And when we talk about the prolactinomas in women, most of the time these prolactinomas at the time of diagnosis are microadenomas. They are small in size and they will usually not present with neurological deficits. Here, in contrast, I want to highlight how would they present in men. In men, if they have a pituitary adenoma, usually at the time of diagnosis, the adenomas are going to be larger in size, and therefore they would, present with either cranial nerve deficits or visual loss or even hypopituitarism, right? Findings like decreased libido, impotence, these are less common and they occur in late stages, right? And also to highlight, gynecomastia as well as galactorrhea is actually rare presentations of pituitary adenoma in men, right? Now, since we now have the diagnosis, we would want to know what is the management, and I would like to invite Dr. Achin to help us in the management of the patient who has been diagnosed with a pituitary microadenoma.
Thank you, ma'am. As ma'am described that it is a case of a pituitary microadenoma measuring in a size less than 10 mm. And the prolactin levels are high, so we suspect it as a case of prolactinoma. As you know, most common functional pituitary adenomas are usually prolactinomas. Now, there are two sets of management of a patient with prolactinoma. One is the medical, second is the surgical. In medical treatment, we've got two drugs with us, the old drug that's bromocriptine and the new drug that's known as cabergoline. Both of the drugs have their own individual advantages and disadvantages. Both of them happen to block the prolactin release from the pituitary because they are having a dopamine agonist activity. If you remember, the hypothalamus transfers a dopamine molecule to the gland pituitary to suppress the prolactin level all the time. And that kind of inhibition has been removed in a adenoma case, so we can give a drug which is a dopaminergic agonist. There are two, one is bromocriptine, cabergoline. Bromocriptine is a short-acting, cabergoline is long-acting. Now, as far as possible, we like to give a drug which is a long-acting drug having a sustained effect. And being a long-acting drug, it's more convenient for the patient to be taken in. Like cabergoline happens to be drug of choice for prolactinoma in general. In general, I am talking for any patient who presents to me with high prolactin level with a documented MRI showing a pituitary adenoma. I will always like to start for cabergoline. Cabergoline has got their own individual advantages. One is long-acting, a better effect, and maybe a more tolerant drug because any dopamine agonist is bound to cause a lot of nausea and vomiting. So it is for the patient's convenience and for a desired effect, we always try to follow cabergoline. Second drug is the old drug, bromocriptine. Bromocriptine happens to be given in specific situations, like females who are desiring fertility and females who are pregnant. Desiring fertility is a time when she can conceive in any cycle. So it is always better to put the patient on a short-acting drug because if I stop the drug, the effect should wear off as early as possible, just to remove the bias of the teratogenic effect of these drugs. Okay, but pregnancy we'll talk later on. Now there is another treatment which is known as the surgical treatment. Surgery is the old surgery, transfemoral resection. Through the transfemoral route, with an endoscopic view, we cast the pituitary, cut it and take it out. But for a patient with microadenoma, we don't go for a surgical treatment. And secondly, surgical treatment has to be given for patients with macroadenoma who are not responding to the medical line of treatment. So the macroadenomas again will always prefer giving a medical line of treatment. As far as visual symptoms in a macroadenoma is concerned, still the drug of choice has to be the medical. If the patient doesn't respond, then we go in for surgery. So in a nutshell, Surgery is not the treatment of choice. It is reserved for people who are having macroadenoma, who are not responding to medical treatment, with or without visual defects. Even with the visual defects of macroadenoma, we always go in for a medical treatment. As far as possible, in a patient with microadenoma, we like to get the serum prolactin done to know the prognosis of patient. In macroadenoma, again serum prolactin will be helpful. Apart from it, MRI is more helpful to know the size of the tumor. Normal range of treatment for a microadenoma can be 2 years. After 2 years, we often see a regression of the prolactinoma in the patient. In macroadenoma, there is no as such regression of the tumor is seen, so it may be continued lifelong. So it depends on the case. So microadenoma, treatment of choice is medical. Macroadenoma, treatment of choice is again medical, but not responding, then going for a surgery. Okay, but there is a specific situation. When we face a female with a prolactinoma and she is already pregnant, what should be done? I'd like to ask Deepti ma'am to discuss that concept for us.
Right. Now, our patient was diagnosed to be a case of pituitary microadenoma, and as advised by the specialist, thank you, Dr. Achin, she was put on bromocriptine and she conceived. Now, I want to take this discussion a little further since we have the specialist with us. Now, she is a woman who is a known case of prolactinoma, and she is pregnant as well. Right. The first and the most important thing is that once the pregnancy is confirmed, the drug has to be stopped. Right. So the drug has to be stopped.
Then the Endocrine Society gives a recommendation against measuring prolactin during pregnancy, because prolactin physiologically rises in pregnancy under the estrogen effect. So it will be not very clear is the rise physiological or pathological due to the tumor growth. So prolactin level, ideally we don't take it as a good marker to know the prognosis of prolactinoma in pregnancy.
Right, which means now we come to a question, then how should we follow up this patient who is a known case and if we are not doing serum prolactin? So what we follow is that we are going to follow up this patient at least every 3 monthly, call her and ask her about her symptoms. So please understand, I'm saying symptoms. Please understand that the routine visual field testing is not indicated. So we will ask the woman about her visual symptoms, about headaches, and only if she does come up with visual symptoms, then we will advise her routine visual field testing. And now I would like to ask Dr. Achin, because there is a doubt amongst the gynecologists or obstetricians as well, should we be routinely doing an MRI during pregnancy?
Although the concept is been very old that MRI is safe in pregnancy, but a routine MRI in pregnancy in patients of prolactinoma is not indicated. It should only be done in patients who develop severe headache and have got a new onset visual symptom, just to know the size of the tumor. Is it growing enough or not? Should we like to operate, or should we like to give some kind of a medical treatment? So the MRI is not routinely indicated in patients of prolactinoma in pregnancy.
Right. And in case she does have these new onset visual symptoms or complains of severe headache, then yes, an MRI is indicated. So we would do an MRI only if she has these symptoms, and if the MRI shows us an enlargement of the adenoma which has been causing these symptoms, we need to now restart the drug. Right. So we would again restart her initially on bromocriptine, and this drug should now be continued throughout the course of the pregnancy, right? And as I said, we would restart again with bromocriptine, and especially this is important, the woman, to whatever drug she responded prior to pregnancy, only that drug should be restarted, right?
So I'd like to just summarize everything in a nutshell, as ma'am explained and sir explained, that the take-home message from our end will be that prolactinomas are a frequent tumor. And the most common presentation, as ma'am said, is amenorrhea and infertility in females with prolactinoma. Macroadenomas are somewhere more common in males, and they come with the visual symptoms, and maybe a slightly later presentation than females is.
Yes.
Then as far as the investigation is concerned, we always rely for a serum prolactin. Along with that, which is a very important clinical point, we need to assess the thyroid status of the patient, because hypothyroidism causing hyperprolactinemia has been documented.
It's very common, yes.
Apart from the investigation, it has to be the radiological investigation. The MRI is going to help us to really put in the final diagnosis. The treatment part is majorly medical treatment. Cabergoline happens to be the old drug of choice. Bromocriptine, if the fertility desired, and especially in pregnancy. And in pregnancy, we don't rely on serum prolactin serial values because it might rise physiological. Neither is MRI being routinely indicated in females who are having prolactinoma in pregnancy. And the most important point, clinical point, is that prolactinomas in pregnancy are usually uneventful, and pregnancy in prolactinoma females is also uneventful. Uneventful in the sense that the pituitary tumors prolactinoma in pregnancy don't grow up in size that much, and secondly, the drugs, if at all they started dose, have that much of deleterious effect. So all is well at the end. If a female with prolactinoma is being diagnosed in pregnancy itself, we'll just wait and watch, let her be off the treatment, and if something wrong happens like severe headache or some visual symptom, then restart the therapy.
Thank you, Dr. Achin. That was a very concise management protocol, and I'm sure it's going to be of a lot of help to our students. And, you know, if you really like our Unplugged sessions and integrated video sessions, please follow us on DAMS Delhi and on the YouTube channel, as well as on Facebook. Thank you so much.